Thank you, Marilee. Welcome, everyone. It's my pleasure tonight to introduce our moderator, Dr. Silvia La Rosa. Dr. La Rosa received her dental degree from CES University in Medellin, Colombia, and her postgraduate degree in periodontics from the University of Illinois, Chicago. She's a diplomat of the American Board of Periodontology, and currently she serves as a member of the Board of Trustees for the Pierce County Dental Foundation. Silvia has incorporated dynamic surgical navigation into her practice since August of 2017. She's been instrumental in providing feedback to ClaroNav to enhance the technology. Dr. La Rosa is in private practice with Nanny La Rosa, and they're both in Tacoma and Gig Harbor, Washington. They combine and treat all aspects of periodontology, oral maxillofacial surgery, dental implants, pathology, and aesthetics. Dr. La Rosa lectures globally on topics related to periodontics, implant dentistry, and surgical navigation. Dr. La Rosa, the screen is all yours. Thank you.
Beth, thank you for the kind introduction. Hi, everyone. As many of our colleagues incorporate dynamic surgical navigation into their practices, there is a broader understanding on how the benefits of this technology have simplified CT-guided surgery. Without further ado, it is my pleasure to introduce Dr. Todd Scheyer, who has, like me, incorporated dynamic surgical navigation into the digital workflow to improve the care that we provide to our patients. Dr. Scheyer received his bachelor's degree in biology with honors from Arizona State University. He attended dental school at Virginia Commonwealth University, from which he graduated magna cum laude, earning clinical and research awards. Dr. Scheyer received his certificate in periodontics, conscious sedation, and a master's degree from the University of Texas Health Science Center at San Antonio and School of Biomedical Science, concentrating on perio-prosthetic regeneration. Dr. Scheyer was awarded the John F. Preacher Award for graduate research in February 2001. He's a diplomate of the American Board of Periodontology. Dr. Scheyer has and currently serves as an officer and a committee member for many outstanding dental organizations. He has served as Senior District 5 Trustee for the American Academy of Periodontology, and it is the past president of the Southwest Society of Periodontists and of the Texas Society of Periodontists. He is in private practice limited to periodontics and implant reconstructive dentistry in Houston, Texas. Dr. Scheyer is a clinical assistant instructor at the University of Texas Dental Branch Houston and guest lecturer for the University of Texas Health Science Center at San Antonio. Dr. Scheyer, the audience and I are so excited to learn from you.
Thank you very much. Give me a moment while I share my screen, and hopefully those people chatting on the left-hand side now have audio. I do see a few people asking about that. And great. So hopefully everybody can see my screen. Beth, please text me if you're not seeing my screen, because I can no longer see the chat room. Welcome everybody. It's my pleasure to be here with you tonight to share my experience with dynamic navigation, and really it's essential to understand where I've come from with this digital workflow that landed me here looking for what's next and hopefully best in our implant practices. Thanks for the kind introduction, Silvia. We share, I think, a common goal to try to bring this technology to the next level with a strong evidence base. My disclosure is important because we do a fair amount of clinical research, and we could not do clinical research without corporate partners. But as always, we want to, as the researcher, the scientist, the publisher, the presenter, maintain our integrity on this and present the data as we see it, and try to leave out our biases when we need to. But it's important to know that, like ClaroNav, without their help, we can't bring things to the table and move things forward for our students and for our patients. I love this quote. You know, this is really the world we're living in. Things are changing so quickly that we can really never catch up. But instead of becoming overwhelmed and neglect the change or the challenges, it's just, I think, our opportunity to reconnect, to capture it, reconnect, and move everything forward. You're never going to be able to do it all. As much as we try, you've got to pick your battles and do the best you can to adopt technology, improve it, get to an implementation standpoint where your team is working together in harmony. And it's hard. It's certainly hard in the world we're living in today. As I mentioned, we're very involved with clinical research. My partner Mike McGuire and I did clinical research for years, and it was very commonplace for people to come to us and say, you know, how do you do clinical research within a private practice setting? This became so popular of a question after lectures that we did an environmental scan with a grant that we co-funded with the American Academy of Perio Foundation that did an environmental scan to see was there indeed a need for this type of research, and yes, there was incredible need. And this startup non-for-profit is now a real thing, conducting NIH-level research with 16 different centers around the United States, mostly perio, but a few recently onboarded oral maxillofacial surgeon centers. These centers have investigators and clinical research coordinators, and they've been calibrated in good clinical practice to do high-level research. This is what keeps us going and keeps us exciting about new technology, is our ability not only to see them and possibly use them, but to investigate them and bring it to an evidence base for our practices and our patients. We also have merged with a great group. It's all about collaboration here at Houston Dental Education Center. 2019 is going to be an epic year. So we've had a collaboration with multiple specialists and general practitioners in Houston to bring all our study clubs together to create a better educational conduit for students, not only our referral base, but graduating students and folks from all over. And the highlight of this here is last March we conducted our first dynamic navigation course where we had George Mandelaris join us for a didactic component, and then we delivered 2 dynamic navigation live surgical cases. So we're trying to bring this education to the next level with digital smile design and dynamic navigation, and trying to encompass all this together for a wonderful learning experience. Our focus today, of course, is how do we succeed in this changing world we're living in? What do we grab from as far as opportunities to make us better, to build efficiency, embracing discovery and technology that sets ourselves apart from our competitor. I tell students all the time, residents getting out, saying, hey, the best thing you could do is go into a little bit of debt and grab all the greatest technology you have and build your brand on technology. The younger generation has an incredible one-up on people like myself and my partner Mike, who's been doing this a lot longer than I have, that they have technology at their fingertips, they're used to it, they can implement it quicker than we can. And that's what's going to set themselves apart when it comes to the competitive landscape we live in. There's no doubt technology is leveling the playing field, making it easier for young folks to catch up with the years of experience that we've had. But this is not going to replace science and evidence. We still have to go back to the data that exists to support our decisions for a technique, for an innovation that ultimately affect our patients' outcome. CBCT, and really not just CBCT, but any digital data that we're using in implant dentistry contains incredible relevant clinical information waiting to be accessed by the software you're using to formulate pre-surgical or pre-treatment questions and retrieve data to determine and develop the clinical performance standards. This is something that George Mandelaris taught me a long time ago when we first started looking at guided surgery. And then, even more important, the ability to interpret that data is proportional to familiarity, right? As with any new technology, the modality, any technological modality, its clinical application becomes related to experience. So myself am not as capable with things like dynamic navigation as those that have been doing it longer than me. There is a learning curve, and I have a slide about that later about learning curves. And you know, if you have all this technology in front of you, if you don't understand it, if you don't have the eyes to see it, like Morty Amsterdam said, you know, you only have eyes with which you see, and but only see that which we know. So you're at a big disadvantage if you can't get in and learn it and understand it and really use it to its true utility. The components of digital workflow, hopefully everybody is aware of these now. It starts with the CBCT and intraoral scanning, good digital photography, now even introducing facial scans for our patients, 3D printing, and then certainly 3D milling, all very relevant to our practice today. So a simple case, let's look at this. This is where I came from, right? This is where we were a few years ago and still practice in this world. But you have a patient comes in with rampant caries. You get your teeth and ridge preservation done. You scan these intraoral scanning to move them into a third-party software to do our planning and digitally print a guide perhaps, or maybe you're at the next level like my dear friend Giancarlo that we run our educational center with that has Zircon milling machines in his practice. So 3D milling, not just for restorations, but for accurate guides to then be able to deliver implants in the planned position. On the other end, then taking an intraoral scan to bring it back to the laboratory phase for digital design and production of abutments and restorations. Delivering an outcome today with a full digital workflow that's efficient and excellent outcomes with good fit of restorations and I believe certainly in the posterior, excellent aesthetic quality of porcelain restorations with the full digital workflow. To avoid these type of things, right? Whether you're using guides or dynamic navigations, this is indeed what we're trying to avoid, the intraoperative surprises. Becoming misguided because we just had a bad day, perhaps, or lost reference points. I see this all the time with residents. Once the flap's reflected and teeth are out, without some guidance, they can get lost quite quickly, and that can be incredibly detrimental to our patient's outcome. So this digital revolution is promised to deliver a seamless delivery of care. We've talked about all these things from the 3D radiographs and impressions, the computer-guided implant planning, CAD-CAM implants, CAD-CAM guides, CAD-CAM provisionals, restorations, mock-ups, you name it, and then here we go, dynamic navigation. How does this fit into the pie? Comparing these two from the static surgery to dynamic navigation, the big difference here, the highlight is that with dynamic navigation, we can change things on the fly, right? If your guide doesn't fit or is delivered a osteotomy preparation in a not good position, we pretty much are aborting the surgery or we're aborting the guide and freehanding it. With dynamic navigation, we have this opportunity to hopefully deliver our plan, but if our plan seems awry, within moments we can shift gears, make alterations, and carry on with some level of guidance in our surgery. And that is the game changer of the technology. However, when you look around educational platforms today, we're pretty much still mainly looking at this type of guided surgery. So I want to share this case because I think the case still shows you where I came from, that even when the rest of the world was doing conversion prostheses with the all-on-4 approach, my dear friend David Goucher and I were trying to do this at a higher level with static guides, utilizing guided surgery to develop a pre-surgical prosthesis. So I'll share this case with you as, again, a reminder of where I've come from and why it's so incredibly exciting for me to move this on to the next level. This is Randy. Randy's been in our practice literally since the early 80s. Mike saw him early on and treated him full mouth perio, and I took out all his maxillary teeth in the early 2000-2001, and it was a real difficult thing for Randy, right? He suffered depression. He lost his job. He went personally bankrupt. It was a. I'm not saying that edentulating him caused all this, but it was a circumstance in which all these things happened together within a 5-year span. So it was my personal mission to ultimately include him in a grant to see him regain his teeth and confidence. So we use three-dimensional planning for this, allowing us to stitch STL files together of a well-fitting denture, creating virtual teeth that overlaid the well-fitting denture, and going through the typical process of 3D planning with a third-party planning software to deliver to us the setup for the implants and the provisional restoration. So here, before surgery, we have gone through the planning process and are using our virtual mock-up of the teeth to mill a full arch restoration. So this isn't a denture that's going to be converted and weakened. This is a PMMA full arch provisional that will be utilized for a long-term provisional restoration. Here you see it back on the 3D models. And here we go to surgery. And in this case, if this guide doesn't work, we're screwed, right? We don't have a backup plan here to be able to deliver this restoration. We have some wiggle room in case we're not completely accurate. But that guide you see in the middle is incredibly important to the success of all the planning we put forth. Here you see the guide fixated and the delivery of implants, 4 in the anterior, 2 in the posterior. Delivery of a provisional restoration that, again, is quite strong as compared to a converted denture. Implant positioning using profile implants on the distal, so we're leaving those implant platforms relatively even with the crest versus one side of it being significantly subcrestal. And then we're bringing it back to the lab to stay in that digital workflow to do our design of the final prosthesis. Right? Copy and paste. Taking the left and building the right for an outstanding final restoration for Randy that rebuilds his smile, phonetics, aesthetics, and confidence, more importantly, I think, for this gentleman. In implant dentistry, all of us, whether we're doing it guided or unguided, implant dentistry has the opportunity to change lives. If we can't save their teeth, we've got an opportunity to give them teeth again with titanium that can certainly rebuild their life and function and aesthetics. And for Randy, this is a powerful moment.
More confidence, and they just feel rock solid. They're just rock solid. My wife says I smile more now, and it's changed my life. It's taken me back 20 years to where I was before going through all this.
So it's a powerful thing we have in our hands, right? Powerful thing to be able to do that for someone. And in this case, it happened, excuse me, went ahead there. This case, it happened, apologize, it happened in a day, right? This was classic teeth in a day with immediate load maxilla. He went through healing for a year. Provisional held up really nice, and then we got him into a full arch zirconia restoration. So from that, now we make this shift. What do we do next? What can we do in the realm of implant dentistry? And there's some things on this screen that I don't have time to talk about tonight, but they're changing in a wonderful way, whether it's dynamic navigation or guides, to be able to take impressions with greater accuracy and eliminating all the doubts we have on passive fit. So again, a discussion for another day, but I believe that dynamic navigation has given us this opportunity to take it to the next level. You know, we came from a realm of kind of like the analogy is the roadmap, right? This is going back to my residency in 1998 of doing model surgery, right? Having a stone model and doing a quick wax up and Been doing some model surgery to figure out if we can get that implant through the central fossa, and is there bone underneath it to make this happen. And we evolved and we advanced to something more like a Garmin, where it gave us some information, maybe not real time, but it gave us a map with from technology, not from a written piece of information, but some digital technology. And I assimilate this to our entrance into guided surgery, right? Like for Randy. And then we got it in our car, so we really getting closer to real time, where we driving down the street and we actually got it right to our left and right, like digital printing, right? We have these in our office to be able to produce a guide or a template, a mock-up rather quickly. But in this day and age, we want it on our phone, and we want it right now. We want it real time. So like Waze, if you're driving down the street and all of a sudden something rolls out into the street, someone's probably going to be able to tell you about it real time, and you can avoid that situation and change your course of action to have a different outcome. In implant dentistry, is there anything that allows us to do that today? And I would suggest no, other than dynamic navigation, to switch on the fly, to provide us accuracy and precision at a very high level. It's important to understand this. Accuracy, the quality or state of being correct or precise, and precision, the quality, condition, or fact of being exact and accurate. So there's these ideas of the bullseye, and here you see that we're neither. We don't have accuracy or precision. Here we have accuracy to get to the bullseye, but not necessarily precision. They're not all grouped together. Here we've got the precision, we've got nice grouping, but we're not in the bullseye. This is what we're aiming for. And in implant dentistry, it appears that dynamic navigation may be able to provide this at a higher level than our static guides have done. If you look at a great review in a moment, it really shows us our ability to evolve and get better. And we're just getting started with this, right? So the excitement is pretty powerful that in another 5 years, where we're going to be can be a wonderful thing for implant dentistry. So looking to be accurately accurate, not precisely inaccurate. Here's the study I was mentioning by Schneider's group, a systematic review. 3,100 articles, had to narrow this down where there's only really 8 articles left. So these are 8 articles have been vetted very well in a systematic review to provide us meaningful data, right? And the results show a mean entry point deviation using static guides of 1 millimeter, right? And the apical deviation 1.6, but maximum up to 7 millimeters. These can be game changers. If you're talking about 7 millimeters, there's a lot of anatomy within 7 millimeters of the apex of your drill or your implant. So although 1 millimeter is not too bad, we have to be considering the variance of using static guides, and how are we going to check and balance ourselves in the process of using them, especially with new users, to make sure we deliver excellent outcomes. And the other conclusion from the systematic review, that there's a considerable number of technique-related perioperative complications observed. Right? So with dynamic navigation surgery, we have a system that's empowered by a motion tracking technology which tracks the position of the patient, the drill, and implant in real time during surgical procedure for ideal precision and accuracy. A recent article, I think a great article done by some dear friends of mine, George and David. David was an associate in our office for the last few years. This showed with an N of 231 that at least this one study did much better than the static guides, right? Focusing on entry points, apex variance, and angle. These are all excellent numbers when we compare it to the static guides. And again, what's I think important is that we got better. So if you look in the lower right hand, the first 50 implants, we didn't do quite as good as the second 50 implants, right? So we knew as operators that we get better. This is the whole thing about familiarity, that any new technology has to be adopted, refined, and then perfected in our workflows. So as I mentioned, this dynamic navigation gives us this motion tracking camera system to hopefully target perfection in our clinics. We have the computer cart and camera. We have the head tracker that's stabilized on the patient's head. The calibration tool used to calibrate the tracer and the drills and the implant. Here's the tracer tool. And just literally 6 to 8 months ago, this lecture was different because we were still using thermoplastic stents. So how exciting is that, to be getting these software updates so frequently and then evolving, getting away from the cumbersome thermoplastic stents now to this trace registration, which may be brand new for you. So for us, we've been using it for a little while, and it's quite remarkable. So the tracing tool allows us to kind of register our patient through fiduciary markers, and then there's a tag on the drill to help the camera communicate with the drill handpiece. So the sequence of events, we're scanning, we're planning. Planning is very intuitive. If you've worked with three-dimensional planning software, this is very, very straightforward. You can use any implant system. It's not system specific, so you can change width and length and change it on the fly, right? You get it into a case. You'll see my second case, I believe today, shows that we made some changes to the original length of the implants, and hey, that's fine, no problem. Tracker has to be stable, right? We've got to be really aware of this, where this head tracker is, that you and your assistant, your team knows that it's been stabilized and now it can't be moved. It's got to be stable. And if you put one on your head, you'll understand that there's a really good chance of it being stable. Once we've gotten that done, we're going to move on to tracing and an accuracy check. So we're using this tracing tool on 4 landmarks, getting 100 points per tooth in 3 to 4 teeth in the arch we're working in. Once it gets those 100 points, it gives you a ta-da, and you move on to your next tooth. And then you go to an accuracy check. So you're taking your tracing tool to a tooth and seeing real time on the screen if you are within a range of accuracy to carry on with your drill registration. And here we go. Now we're using the tool to calibrate our drills. Actually, you need to calibrate the handpiece first, then put the drill in and move on to that, and then do an accuracy check with the drill, as you're seeing right here. So just like we did with the tracing tool, we're checking it for accuracy with the drill. We're about to begin our osteotomy preparation, and obviously we're going to move on to our drilling, trying to get into the bullseye, right? Taking our time, using two-handed drilling oftentimes to stabilize the drill. It's a bit of a paradigm shift here, right? Having always spent our time looking at our patient or the surgical site, now we're looking at a computer screen. So for my young associate, David, it was quite simple. For someone like myself, it took a bit longer to get it. And for my partner, Mike, even a bit longer. So it's unbelievable technology, but as I mentioned before, there is a learning curve. And I would say I'm not finished with it yet, right? When we move on to more complex type cases, my journey through this has been to, as I do something new, do a new type case, I still have a backup plan. I still have a guide, right? And I do dynamic navigation with a backup guide to hold my check and balance. This is an incredible slide, one of George's slides, which I think, actually it's probably a Clarinet slide, but I got it from George. And it's incredible understanding that they're just like everything we do in the laboratory, in dentistry, there's entry points of error. And we need to understand where they are and learn how to circumvent them or regain accuracy and lack of errors by going through the process again. So it's an incredible loop that we have to do our calibration and accuracy checks, registration appropriately, and make sure this is all moving smoothly to avoid errors that can be detrimental to the actual surgery. So let's look at a case of a lady with internal root resorption on tooth number 8. She also had some crowding that she's always would like to change, and now she's got a real strong reason to do that. You see the resorption here on the right central incisor, symptomatic now because of its involvement in the pulp. And I take out the tooth and do ridge preservation, and we move her into Invisalign to straighten her teeth, eliminate the crowding, reduce the overbite, and now have her ready for implant placement. Here you see our dynamic navigation planning software and the pan view and the focus view. Placing her implant, you see a virtual tooth I've placed in there to help with my planning. Obviously, you can certainly use a intraoral scanner to scan in a provisional restoration or wax up and merge that STL file into the Navident planning software. Here you see me doing our trace registration. Now our tracing in the mouth, waving this little probe type device over the surface of the tooth structure. It's important to know that natural teeth work wonderful for this. If you have a lot of metal or porcelain restorations, it can be a challenge. I believe we'll get through this, but it's right now it's important, I believe, to have natural teeth as your fiduciaries. Now we're doing our accuracy check to see that we are within a realm of comfort on our registration and tracing. Now we're going to do our drill tip registration and accuracy check. Here you see again taking the tip of that drill and putting it on known landmarks in the mouth to see if I'm within a range of accuracy, and then moving on to our drilling. As with most anterior teeth, you can see I'm even erring a little bit towards the palatal on the plan. Now, this is another fantastic thing about dynamic navigation, being able to register your implant too. So you're going to be placing your implant just like you're placing a drill to deliver your implant into the planned position. In some, not all, but in some cases, this can be important. If you have some type of weakness on the buccal plate, you can get led astray a little bit by being pushed from the lingual towards the buccal. This allows us to be watching our implant accuracy as we're putting it into the osteotomy site. And this too, this is, I just love this, especially as a teacher, to have something like a value nav, to take a preoperative scan with your plan and then superimpose a postoperative scan to really see how we delivered, right? Unbelievable technology to help students, right? To show them what they've done, how they've performed, where did we go wrong, and then make these measures like we have here. We did pretty good, right? The entry point deviation was 1/2 millimeter. The apex was about 1/2 millimeter. Excuse me, the apex 3D was 1/2 millimeter, and the vertical was 0.08 millimeters with 1.45 degrees of angle difference. That's wonderful information, but think about putting this into clinical research, right? To have a really high-level method of capturing the performance that we delivered with the technology we're studying. That is a powerful thing. For this patient, we're taking a digital scan of the implant site. Really a great thing to have in a surgical office today. Fantastic relationship builder for our referrals to scan our implants for them so that they can then either have us or them develop a digital provisional restoration. Here you see the provisional delivered day of. And 14 days later, we've had some nice soft tissue adaptation and kind of set up nicely for the final restoration. The disclaimer here is, trust me, the dentist and myself wanted to pay for a restoration on number 9. We would have done everything we could to pay for that restoration. The patient wanted no part of it. And you'll see from her smile, you know, in a moment, that she's content. She's happy as a lark to have the crowding taken away and a new front tooth that she's very content with. So her smile line doesn't show it, but geez, man, number 9 just begs a mesial bonded restoration. See on the far right, excellent crestal bone levels and a digital designed abutment and final restoration. This case, I think, is a powerful representation of what this technology can do for us. Young man, 18, going off to college. His mom comes in. I do a scan and plan. At this time, planned it with Implant, and I told them that this is going to be a challenge. This is a case where we may want to consider some resin bonded bridges, right? These are tight spaces, and the orthodontist moved the lateral incisors into the centrals. I don't know why, but they did, and this is what we're left with. And they listened to my advice, and they went away. But a year later, they showed up, and they said, you know what? These resin bonded bridges have popped off 3 times in the year, and we want to relook at implants. So dynamic navigation was in our office at this point. We took intraoral scans, did a digital wax up for these centrals, went through the planning process. This young man had plenty of bone. Bone was not his problem, space was. But in the planning process, we found out if we could be accurate and precise with our delivery of implants, we could thread the needle. So will this technology allow me to thread the needle? Here you see on the right side, we're preparing our osteotomies, trying to get into the proper position before drilling. So it basically just holds steady at the right occlusal position before advancing the drill. Advance the drill once you're very comfortable with where you are. Slowly but surely. Here you see the excellent sites we have for implant placement, my delivery of osteotomies, implants, and we were successful, right? And I'm not so sure I would trust a guide, right? Because even if the guide was dead on, there would have been a little bit of lack of confidence on the accuracy of the fit of the guide. Whereas with dynamic navigation, we could trust and verify along the way, and if we weren't quite there, we could make a change to the plan to carry us forward. Quite honestly, the only change in plan here, we moved from planning 13mm implants to 11.5mm implants. Here's our value nav, which actually shows the variable there where the yellow is planned and the red is placed, and it really the big variance there is just the fact that we placed shorter implants than we planned. And here's the digital scan. So we're taking digital scans to deliver. In this case, going back to college, we delivered final restorations. So we went right from healing abutments to final restorations. This is the day of seating. And now post-loading x-rays showing stable crestal bone levels and no breakdown around the bone adjacent to those teeth. And a happy patient with fixed restorations, and most importantly, his mom and dad are happy. Here's a recent case done with a team, excellent restorative dentist, Norman Chu. It involved excellent endodontist to try to salvage this tooth. Unfortunately, that doesn't always work with these external root resorption cases, and it's very outstanding lab technician, Gilbert Young. Here's our patient, somewhat of a high smile line, suffered trauma on 8 and 9 years ago, severe root resorption on the palatal of number 8, was treated with a flap and repair by our endodontist. And unfortunately, as time went on, the fistula developed on the buccal. Big problem here, because if you look closely, I'll show you in a moment, when you look closely on the x-ray, the bone is breaking down interproximal to 7 and 8. We do have some protrusive interferences here. The dentist I'm working with here is an absolute master of occlusion. So lucky to have him on our team to help us work out these challenging occlusion cases. So we're just looking at his photography here. Here we're honing in on the draining fistula. And you see on the right-hand side, we've got relatively good crestal bone levels on the mesial of number 8, but on the distal, it's very suspect that it's been destroyed by this infection. So we have scanned and planned him for extraction and potential immediate implant placement. The patient knows that if I don't feel comfortable with primary stability or the amount of bone breakdown, we'll abort and just graft the socket. So going through the same process that you've already seen, moving on to drilling the osteotomy site there on the right. I don't know about you all, but the pictures of the teeth on the left. You see the first picture of the tooth is that repair on the lingual. You look at the side of the tooth, this almost like a cemental tear or flaking of the root surfaces off. We see this so much in endodontically treated teeth that we ultimately take out, that there's you know, a devitalized tooth changes over time, and it's not uncommon. I've had a number of patients where we fish out these flakes of or veneer type cemental tears in save teeth. This is a great picture illustrating that type of veneer fracture of the outer layer of the root surface. And here we're able to use dynamic navigation to deliver our implant into the planned position. We're going to do our socket grafting and take our digital scan. Here we're taking our digital scan. So whether you're doing this for immediate provisionalization, which we did not in this case because of the amount of grafting necessary, or you're doing it for your restorative dentist to use later without having to take an impression, it's a valuable resource for the dental team. Now we're going to, after socket preservation, we're just illustrating a 6mm biopsy punch is appropriate to get our harvest of a full thickness epithelial and connective tissue graft to place over our implant site using here's like 7/0 Resorba sutures to fixate that, and then some collagen in the palatal donor site that heals really well with just an Essex type retainer over that collagen and some resorbable stitches. Here's our implant position you see and his provisional bonded restoration. Sometime later, moving to a healing cap and the delivery of our digitally designed and fabricated provisional screw-retained provisional restoration that Norman's going to place, leaving the embrasures as open possible. The ultimate treatment plan is to also restore number 9, but we're going to let nature take its course around the implant to maximize soft tissue fill before we move on to final restorations. Here we are kind of at a current status, and the next step for him was accomplished just a few weeks ago, and that is adding some more connective tissue on the facial of the implant. My preference today in these aesthetic cases is to do this after provisionalization, so I can take off the provisional and use microsurgery to approach the tunnel through the sulcus. I think this is a really nice way, and then when you put the provisional back on, it does a wonderful job of maintaining the connective tissue in position. These microblades are wonderful for our dissection, but this is indeed a topic of discussion for another day. As I mentioned before, this is important, right? The cases that we're doing, it takes a while to get proficient in anything we do. And if we look at other simulators that have been published in the medicine arenas for colonoscopies, at least 60 simulations. For bypass surgery, 15 to 100. Endovascular neurosurgery, 100 to 500 cases. You know, where is it for implant dentistry? I tell you what, if you got a good checklist, you got a good team, systems, teachers, you can get there a little bit quicker. But I feel with the dynamic navigation for the experienced surgery, it probably lies somewhere in between 50 and 100. It's going to be different for every operator, but you can get there, and once you get there, what a wonderful feeling to have that we can deliver care for our patients that's more accurate, more precise. What's next? You know, piezo surgery, endo, and it's not really what's next, it's happening right now. But you think about it, the applications of this in dental surgery are outstanding, and we're going to get there. You know, having used it for implant therapy now for more than 2 years, we're ready to graduate on to some of these bigger and better things. The idea of those that place pterygoids or zygoma implants, what a wonderful application of this technology, right? I saw a case yesterday posted on the Navigational group utilizing it for just that. So I'm so excited about the future with this technology. I think in summary, this technology allows you to operate without a guide. We get real-time feedback of the osteotomy preparation and implant placement for hopefully optimal accuracy and precision, and we can make changes real-time on the fly during our surgery. So this passion in learning, I want to share with you all. Please, if you haven't had the opportunity, check out our website. Our practice website is periohealth.com, but the new one is IHDS-CE, and that's our Institute for Houston Dental Synergy, bringing together prosthodontists and periodontists and endodontists and orthodontists and general practitioners all together to create courses for dentists that want to advance themselves to be better dentists and adopt new technologies or new ideas for their practice that brings them to the next level. I really thank you guys for your attention. I thank Beth and the Navident team for asking me to share this with you tonight. Silvia for her kind introduction and her passion and delivery of outstanding programs for our academy. She did an outstanding job last year in Vancouver, and everybody, thanks for your attention. And I'm gonna, I think, come out of this and get back to the chat room to see if there's any questions. Oh, one more ploy is, please, as you all, I'm sure, trying to get into the social media game. This is new to me, but we're on there and we're trying to stay relevant. So check us out on our Instagram page at Periohealth Professionals, and this new IHDS educational platform that we really feel like is going to change education for dentists in the Houston area and from beyond. Thanks, everybody.
Todd, that was an outstanding presentation. Your cases were well planned, they were efficiently and accurately executed. I praise you for your presentation on your cases as well. It was a delight to watch. Thank you. So I do have actually a question myself that I want to ask. So you very nicely, you demonstrated all the benefits of dynamic surgical navigation. You demonstrated the real-time verification of your restoratively driven implant osteotomies and your implant placement. You demonstrated the real-time visualization of the anatomical structures as you were working, and you were talking about, your anterior case. Looking at that lower incisor case, the lateral incisors, that is a tough case. One that you definitely have to have real-time visualization, and in one that you can definitely not use on a study guide due to the brokenness of the study guide to begin with.
You have a pilot guide only.
Yeah. I mean, all these benefits, right, you can only use the pilot guide and that's it. And then, basically you have to finish the case freehand and at that point hope for the best, right? So having dynamic navigation allows you to be very accurate on those very difficult areas. The versatility, you were, changing the plan within surgery. We all know that, and we all honor study guides. We all have learned with the study guides. We all use them. However, the reality is not being able to change the plan within surgery is a big disadvantage, and that's why the name is static, right? It's a very static solution. So to me, I think that all these benefits just really, really make of dynamic navigation a really to-go-to for all the cases. From the digital planning to the execution, for sure. And one of the things I think we need to elaborate on is on the fiducial independence with dynamic surgical navigation, which I think is definitely the tipping point of the technology, and one that has not only simplified the digital workflow, but also CT-guided surgery. So do you mind elaborating a little bit on the fiducial independence? So you can explain to the audience.
The trace in place. Yeah. So the ability to avoid that thermoplastic stent that we were using just a short time ago, it improves the workflow in our offices. If you think about it, the patient, where this is a workhorse, in my opinion, is patients that come in with a fractured tooth and they would like to have same-day treatment, right? So they're coming in for CT scan and intraoral scan, the planning in the delivery of care, extraction, intermediate implant placement. That's where we use it the most. And in those situations, at the time of scanning the patient, we were also making a thermoplastic stent that held the fiduciary. And this one has another entry point of error, right? So even though it appears to be working pretty well, there's some more error possibilities than there are with the trace and place registration. So I think it's kind of monumental breakthrough to add trace and place, and really is the one big edge we have now compared to the competitors in the marketplace to be able to do that, to improve efficiency, but at the same time reduce error, increasing accuracy for our cases. I noticed somewhere in there in the questioning that someone was asking about publications, and I think maybe Beth is adding that. But there are papers now that show the accuracy of Navident as compared to static guides, and I hope there will be some really important clinical trials forthcoming showing specifically to trace in place. We're working on publishing a case series using trace in place, not to compare it to anything, just to introduce the concept to the readers that it's real, it's exciting, and it has the ability to really change this in a big way. Is there anything you'd add on it? I mean, other than the efficiency we have and the knowledge that it's reducing error points, anything else you'd add about trace in place?
Right, and most importantly, with trace in place, the fiducial independence, what is really important and advantageous is it pretty much allows you to use one CBCT. So with the one same CBCT, you take, you do your diagnosis, you do your plan, and you do your placement. Unlike when having, as we know, fiducial, let's start with that, is of course a marker. But fiducials are external markers that have to be incorporated into a stent. Therefore, the patient has to be scanned with the stent in the mouth, and then you have to translate that to the surgery. So that basically, again, the major benefits of the fiducial independence is you don't need to take a secondary scan, and certainly you don't need to have a stent per se, which we know that the disadvantages with the thermoplastic material. We use the Navi stent. I know you use it. I used it myself. If it's not well fitted, if it's if the patient from the time of the making of the stent to the time of the surgery, a tooth breaks or there is a variation or restoration, it doesn't fit. You have to start over. So yeah, those are the two main advantages: is lack of need of secondary CBCT and eliminating the need of the external fiducial and using the high contrast landmarks in the mouth, which are the teeth or any an implant or a bracket or anything. Yeah,
like those that are successfully using the technology for full arch are doing that via a miniature implant and a bonded fiduciary to that implant. And I have not used that protocol yet, but those that have had success with it. So it's not limited to single tooth dentistry, that's for sure.
Right. I see a question here. How long does it take for the tracing process? Do you want to?
Yeah, I mean, I think with again, the learning curve issue certainly is there, but once you become proficient at it, it should take a few minutes. At first, you may be repeating it. If you have to repeat it, that's kind of the deal breaker, right? You can turn into a 2 or 3 minute process to a 10 or 15 minute process if you're not happy with your accuracy checks. But once you've gotten it down and you feel like you're cruising at a proficient pace, then it's minutes.
Right. And one thing to remember with the tracing, I mean, tracing, yes, it's really a few minutes. I mean, like you were demonstrating, you're basically tracing 100 points per landmark chosen, right? So that is a fairly quick, step. If you choose anywhere between, 3 to 6 landmarks, yeah, it may take a few minutes, if no less. And if you need to repeat it within the procedure, it definitely doesn't really change much of your time, procedural time. All right. Now I want to add something. You were talking about the learning curve, and that is, I think, something very important to talk about. With every procedure, we all have a learning curve. Any technology that we incorporate in a practice, any procedure that we learn, there is a learning curve. My always greatest recommendation to everyone when it comes down to any technology, in this case dynamic navigation, is practice, practice, practice. And most importantly, motivate the team, because they need to understand that we're doing so much better and they can see it. Actually, what I do for fun is I have demonstrated to my team through EvaluNav how accurate the system is. And like you were demonstrating in your case, which is absolutely valuable, you were showing deviations of 0.08. Those are microns. We're used to planning our cases in millimeters, and now you're measuring your success in microns. That is fascinating to me. And I think that's something that we need to, relate to other clinicians, relate to the team, so they can really be, as I am, and you are, I'm sure, at a wow with the technology.
Yeah, I think that's powerful. I mean, even Dr. Chu mentioned it here in the chat box that this can, if you talk about it and display it and educate your patients and your team and other referrals, this is a powerful confidence builder. If you're the patient, someone can show you this technology that's all aimed at accuracy and precision. What surgeon do you want putting your implants in, right? You want someone that's using the best technology to be as accurate and precise as possible, or do you want someone that's freehanding it because they're a good surgeon? I mean, I've been doing this a long time now. I hate to say it, but I have, and I know I'm better when I have a check on my balance, right? I know I'm better when I have a guide or dynamic navigation, because if we're busy and we're going from patient to patient, it's critical that we have something to hold us in check.
Perfect. So a question regarding the registration and checking basically how accurate was the registration, and that is a very important question that has been asked. And I guess, to address that, it's very important to check the accuracy of that registration. I don't know if you want to elaborate a little bit on that, or you want me to, but I think we need to talk about, again, the accuracy of the tracing and how we check for that accuracy.
It's kind of comical, but this is live webinars. My cleaning crew just showed up in my building, and I've got to tell them to shut off the vacuum cleaner. So I'm going to mute, and you can address that question. I'll be right back.
Perfect. So, going about the trace registration again, trace registration, just to begin, let's define what it is the way we register the patient's jaw to the CBCT, to their CBCT. The tracing, again, is very important because that is how we are certain that we are accurate throughout the procedure. So you got it taken care of, fantastic. So basically to verify the accuracy of that trace registration, once you complete the tracing of 100 points for the landmarks, you go to a different screen, or automatically goes to a different screen. And the tracer tool, you put in contact with the landmarks or the adjacent teeth of your surgical area. You want to verify the accuracy on all the surfaces, all the planes, the buccal, the lingual, the proximal, the occlusal, and the actual computer will tell you want to be on the surface of that particular landmark. And it will even give you numeric deviations of the accuracy. So if you're within between 0 to 0.5, the system is highly accurate. And if there's a larger deviation from there, then you want to repeat the trace registration if need be, which should only take you a few minutes.
Yeah, I was going to try to show, rather than sharing my screen, just try to show a picture here of the display, because you can get a display of your tracing. Let me just see if I can pull that up. I think it'd be beneficial to the audience to see this, because it's fascinating. The computers provide us so much information to drive this forward, and everybody can see that image in the middle of the screen. Sylvia, can you see that?
I can, yeah.
Yeah, so this is showing a tracing, and the green is good, the red is not. So it's critical that that little probe stays against the tooth structure, and if you have a tracing like this, you best be doing it again. And this is one of my own cases where I obviously didn't do a great job. And if I had carried on, I would have noticed on my accuracy check that I wasn't accurate. So you have this ability to check your tracing, as one of the people asked.
Correct. That is correct. Fantastic. Well, Todd, I think we have pretty much answered all the questions on the internal chat as well as live. Do you have any last thoughts that you can think of before we turn it over to Beth?
No, I don't think so. Thanks, everybody. Thank you, Sylvia, very much.
Oh, thank you. It was wonderful watching your presentation. Thank you. Very well done.
Thank you.
Beth?
Thank you, everyone. It was a great presentation. I really appreciate the questions that we had as well. We have, I just wanted to share with you before we get to the CE link here. We have several courses coming up that I think you should check out. If you're going to the AAP, we have 2 opportunities for hands-on workshops led by Dr. George Mandelaris, Silvia La Rosa, and Brad DeRoot. You can find out information about that on the Perio website. Also, if you're going to the Digital Dentistry Society Conference in Baden-Baden, Germany, we'll have another hands-on there with Dr. Silvia La Rosa and Luigi Stefanelli. Check that out. The link is there as well. And then coming up in October, this is pretty exciting. We have a 2-day course. It's a Thursday and a Friday where there will be not only a hands-on, but you'll have the opportunity to do live surgeries. The patients and all supplies are provided. And then again, we have several over-the-shoulder programs coming up. The next one will be with George Mandelaris in Chicago. This one happens to be the day before the Amos Implant meeting, which is also in Chicago. So if you have any questions on any courses or any other the educational opportunities, feel free to contact me, Beth@claronav.com, or you can go on our website, which is www.claronav.com. So thank you all so very, very much. I appreciate the attendance and the wonderful presentation from our faculty. Have a good night, everyone.